So yeah, the study is pitched as mental health and wellbeing of workers during the COVID-19 pandemic. But actually, it's developed on from that a bit. That's definitely how it started. It was because of the pandemic that we started the study back in April 2020. We're doing a round of data collection in the next couple of weeks, actually, which is going to be a fourth data collection point, which is very much focused on mental health still, but not so much about COVID-19 and the impact of the pandemic on people's mental health, but more generally, the mental health of healthcare workers. But to tell you about the study, so yeah, we think we're the largest UK study of mental health and wellbeing of healthcare workers. We think it's really important that we've included all staff, so not just clinical staff. There have been quite a lot of these kinds of studies of mental health of healthcare workers, and lots of those are focused on specific staff groups or departments, so nurses, for example, or ICU as departments. We've included anyone who works in one of the 18 NHS trusts in England that are included as participating sites in the study. We're also longitudinal, so I mentioned we're doing a fourth round of data collection. We've also collected data, so from baseline and then 6 months later and then 12 months later from each participant, as I said, starting from April 2020. We've done a big range of analyses on that data. So it was an online survey, so sort of tick box survey type data. But we've also carried out a number of qualitative interviews with people about different topics. And we've also done an RCT of a wellbeing app for staff. The overarching protocol paper, you can see that was published in BMJ Open some time ago. So I've added the link there. And I will share these slides afterwards if people want to have those. So to give you a sense of what our cohort looks like, as I said, we've got 18 trusts that are taking part in England. We've got just over 23,000 participants as our baseline cohort. That's from a population of 152,000. So that's a 15% overall response rate, which is not fantastic, but it's also not terrible. And actually, it's a lot better than quite a lot of other studies that have done similar things to us. And really importantly, as far as we know, we're the only weighted data set of a similar kind of study. So we obtained data from HR departments of participating trusts on some key demographics so that we were able to weight our data proportionally to better represent the population from which our sample has come. So you can see there's some overall numbers on the NHS workforce, what our sample looked like before weighting, and then the weighted sample to make that a little bit more representative. So here are some headline results on the mental health measures that we've used. So you can see 3 bars there for each measure. So we used the GHQ to look at general psychological health, GAD-7 to look at anxiety, PHQ-9 for depression, and so on. And so those 3 bars for each of the measures are baseline 6-month and 12-month proportions meeting cutoff on those measures. So again, for example, with the GHQ at baseline, 52% of our participants met a cutoff score, which means they met a score where it indicates they're experiencing symptoms of mental distress, mental ill health. Similarly for GAD-7, 23% at baseline met that cutoff score that indicates they're experiencing symptoms of an anxiety disorder of some type. But importantly, these are not diagnostic measures, they're screening measures. So they give us a sense of people experiencing symptoms rather than the number of people with a diagnosable disorder. There's another caveat as well, which is that our data collection points are not points, they're periods. We had really long data collection period at the start to get as many people into the study as we could. So our baseline data collection period went from April 2020 till January 2021. Now, because we followed up each individual 6 months after they'd completed their baseline data, that obviously meant there's a bit of overlap there. So there were people who started the survey early in our data collection round, their baseline one. 6 months later, we asked them to do their second survey, and then we were still recruiting people to baseline while they were doing that. So there's this overlap between the data collection periods. And I think it's reasonable for people to say, well, you know, meaningful are the numbers in this kind of graph here, if actually what you're measuring are not time points, but these overlapping time periods. That's reasonable. I think what these numbers in the graph show are a snapshot. Oh, I'm getting a bit of an echo there, which I think means someone might not be on mute. Okay, that's better. So yeah, so they give us a snapshot of prevalence over these 3 overlapping 10-month time periods. But yeah, we've also looked at a bit more detail at these results. So we ran some multi-level, multivariable logistic regression analyses, and overall, there's obviously a lot of outcomes there that we looked at separately with a number of different variables included in those models. Overall, the variables of being female, of being in a younger age group, and of having experienced moral injury, those people were more likely to experience symptoms of mental ill health. And I'll come back to what moral injury is just a little bit later on for anyone who isn't aware of that term, hasn't come across that yet. And then for some outcomes, there were also some other variables that seem to be associated with worse outcomes. So not being in a relationship, being lower paid, feeling unsupported, and so on. And there is an exception to this. The audit, which measured alcohol misuse, male and white participants were much more likely to report alcohol misuse than other participants. And there is a bit of a discussion about whether some of the mental health measures, like the GAD for anxiety, the PHQ for depression, and so on, whether they're capturing the experiences of men as well as they are experiences of women. Women almost always come out as being at higher risk of those kinds of outcomes compared to men. And I think there is a question there. Is that because women are at higher risk of anxiety and depression, or is it that those measures aren't really capturing men's experience? Whereas with the alcohol misuse, that is capturing more of the sense of men's distress. Some interesting questions that are still to be answered, I think. Now, as I said, we use those screening measures in the survey, but they don't give us a sense of the level of diagnostic disorder in this population. However, diagnostic interviews do. So we ran a 2-phase epidemiological study to look at this. So we had a subsample of our original baseline participant group, where we used 50% of that sample who met that cutoff score on GHQ, indicating some symptoms of mental ill health. 50% didn't meet that cutoff. And we screened them using diagnostic interviews. So we did interviews using the CIS-R with 243 participants. That was looking at depression and anxiety. So these are one-to-one clinical interviews with people, the kind of interviews that you would use if you were diagnosing someone with a mental health disorder in a clinical setting. And then we also did the CAPS-5 with 94 participants looking at PTSD, experiences of PTSD. And so we now have, from that data, a much more accurate prevalence for the population at risk, which is English healthcare workers. So you can see in the table there, when we use the screening tool for depression, 27% of our participants reported symptoms of depression. But when we used the diagnostic interview, that showed that 13% were meeting the criteria for having a diagnosable depressive disorder. Similarly, for anxiety, 22% reported symptoms of anxiety using the screening tool. For the diagnostic interview, 14% were meeting the criteria for having an anxiety disorder. And then for PTSD, a quarter of our participants were reporting symptoms, but with the diagnostic interview, 8% were experiencing a diagnosable disorder of PTSD. So there are a couple of things to say about this paper, which, by the way, is out in Lancet Psychiatry. Just a plug there. Oh, I seem to have lost my sharing. I think someone else has started sharing and kicked me out. Let me just try sharing again. Okay, hopefully people can see that again. So yes, that was maybe maybe that was because I was trying to plug our Lancet Psychiatry paper there. But yeah, we're very pleased that this one got into Lancet Psychiatry. So yeah, so a few things to say there. It's so important not to pathologize normal distress, and I think that's what one of the things that is criticised about. Could whoever's just joined mute themselves? Thank you. One of the things that's often criticised about those kinds of screening tools that are used in surveys is that actually people might be ticking the boxes and meet a cutoff, but actually they're just reporting perfectly normal distress that will likely resolve without the need for intervention. Equally, it's obviously really important to support people who do need that help. And diagnostic interviews help us to identify with much more accuracy the people who do need support. Those numbers, the 13% meeting criteria for depression and so on, they are still worryingly high, even though obviously they're lower than the screening tools suggest the population is at risk. PTSD in particular, 8% is about double the prevalence of PTSD you'd see in the general population. So that is still quite a concern. Okay, so I'm giving you a bit of a whistle-stop tour here of all the different analyses we've done. And this one I thought was interesting because it's not something that I had done before. It's quite a different method that it was very new to me. So structural topic modelling of free text survey data. So I'm sure lots of us have used free text survey questions in sort of the kind of online surveys that we use, where you just say, do you want to tell us anything else? And we used one of those at the end of the baseline NHS check survey, where we said, is there anything else you think we should know about your experiences? And we got 7,000, nearly 7,500 responses to that question. Some of them were just a couple of words, some of them wrote a lot. Obviously 7,500 participants is not really a very practical number to go through and analyse using a qualitative method. So like, for example, reflexive thematic analysis is sort of a very standard method to analyse qualitative data. 7,500 responses is just not practical to analyse manually. So we used this text mining technique, structural topic modelling, and that uses correlations between word frequencies to define topics. So that the modelling defines the topics, and then we used standard reflexive thematic analysis on those topics and the excerpts that represented the topics. So it's essentially a way of the text mining technique boiling down these 7,500 responses into sort of themes for us, and then of doing a traditional thematic analysis. I won't go through the details here. I'm not an expert in STM. We had a very helpful statistician who is an expert in that, who actually did that work for us, and then we carried out the thematic analysis. So I'll just focus more on what came out of this work. And the quotes that we had, they really emphasised the sort of the positives and the negatives of some of the experiences in the pandemic. So lots of people talked about the increased workload that they faced, the problems with lack of PPE, which is very sort of pertinent thing early on in the pandemic, and the really inconsistent guidance and advice that they got from management, from their superiors, from the government as well. There were really differing experiences of home working with. Some people thought it was a really brilliant thing. They were getting to see their families more, it was less busy, and some people thought it was really awful, and they felt as though they were in positions, particularly people working in mental health, where they were having to do work from environments like their own bedroom, where it was really inappropriate, and that was a very negative experience for them. And overall, the benefits of supportive leadership and of people's peers in helping to deal with all of these challenges was really, really important. That's something that's come out of a lot of research, I think, and is just backed up by this. One of the benefits of STM is that you can, as well as doing this, as well as sort of managing this huge amount of data that wouldn't be able to be analysed otherwise, you can also look at the themes in terms of demographics and of time, because we had data that spanned the whole of the baseline data collection period, so 10 months. And it was really interesting to look at the differences across time in terms of what people were talking about, whether what was most important to people at different time points. And so discussion of home working, as you might expect, decreased over time. Discussion of workplace challenges increased. And perhaps again, unsurprisingly, discussion of people's mental health was lowest between September to November 2020, which was that sort of lull after the first wave when some restrictions had lifted, things had eased off. So yeah, that paper is out in PLOS One. And just to give you a sense of some of the things that people talked about and some of the themes that we looked at, there are some of the quotes. So yeah, the issue of workload and burnout in particular, I think, is really pertinent still, and perhaps even more so now. So that person saying we've been massively understaffed through COVID due to staff sickness, mostly under stress rather than having to isolate, and that's impacted on the stress levels of remaining staff who are firefighting, trying to stay afloat. And I'll come back to this in some talking about some of the other research we've done. I think there's a real problem with that sort of the cyclical nature of this, that staff go off sick due to the stress of pressures of work. That then places more stress on the remaining staff, and it's not the fault of those who go off sick, obviously, but there are even fewer staff then to carry out the things that need to be done. There's more stress on people, they go off sick, and it's just this real sort of cycle of things that there needs to be some kind of intervention somewhere. Okay, moving on. So this is an analysis, again, of some free text data, but also some of the quantitative data. So this was a mixed methods paper where we did a fairly standard quantitative analysis, fairly standard qualitative analysis, but of the same topic. So the question in the survey was about whether people had provided worse care than usual to their patients. And if people had reported doing that at all, then there was a free text question that we gave people the option to answer, to just tell us more about that. So there were 1,500 participants who provided responses to that free text data. And so we did a standard reflexive thematic analysis on that. So 1,500 responses was just about within what's feasible to look through. The length of the total text was similar to a sort of 20 to 30 participant qualitative interview type study. And then on the basis of what that qualitative analysis showed, we included some variables in a logistic regression model to look at factors associated with providing worse care. And there were 4,000 participants included in that. So here's a theme map. So this is a little bit of a complicated slide, but you can see one of the main themes was feeling under-resourced. And again, this is coming out in quite a lot of the work we've done. So staff sickness and unworkably low number of staffing numbers lead to these really dangerously high patient caseloads. And being under-resourced leads to this sense of firefighting. So patients are only being seen who have conditions which are life or limb threatening. There are closures and delays. People reporting they'd seen multiple stillbirths from reduced care that people received during the pandemic. That under-resourcing led to a lot of care being virtual, and lots of staff reported that as being quite impersonal, and actually digitally excluding people who were probably the most vulnerable, so older people, people who didn't have access to being online so much, refugees and asylum seekers in particular. And yeah, so delivering therapy, for example, virtually, when there really wasn't much of an evidence base to suggest that that was effective. And all of those things leading to this sense of crushing pressure that people reported to us. And this participant said, even the army give their soldiers R&R after the battle, but not the NHS. The whole team's frustrated, burned out and tired. And then we used some of those variables in this quantitative analysis. Again, this was multi-level analysis to account for the fact that our data is clustered within trusts. So we've got individuals within a trust, and the assumption in this multi-level kind of modelling is that they're more similar to each other than they will be to people in other trusts. So the data is clustered, multivariable logistic regression model. we adjusted for a number of variables there, as you can see, including burnout and moral injury. And because those were two things that people really talked about quite a lot in the qualitative work. We also included GHQ as a sort of overarching sense of mental health. And you can see some of the significant results there. So people of mixed ethnicity were less likely than white participants to report providing worse care, though there were very small numbers in those categories. So there's some sort of questions about how accurate those numbers are. Non-clinical staff obviously were less likely to report providing worse care than doctors. Those providing worse care at baseline were perhaps more likely to report the same at 6 months, and people who were burnt out and who experienced moral injury at baseline were more likely to report providing worse care at 6 months. And that's the bit that really came out of the qualitative results. So it's really interesting that that was borne out in the quantitative data as well. I'm just going to check the time. Sorry, to make sure I'm not going too far over. I think perhaps I've just stopped sharing, so apologies for that. Let me just quickly get back in there. I'm going to just skip over a couple more of these because I'm running out of time. I just want to talk to you about the RCT. So this randomized controlled trial was of a smartphone wellbeing app. So Koa Health is a company that has a foundation's wellbeing app. And the idea was that this app would help improve mental health in healthcare workers. We had just over 1,000 participants in total. 500 were in the intervention group. Sorry, 502 were in the intervention group, and they received access to this app for 8 weeks. And the other 500 participants were in a waitlist control group. So they received access to the app after that 8-week intervention period. So everyone did get to use the app in the end. We collected measures at baseline, at 4 weeks and at 8 weeks, and the primary outcome was the GHQ. So not many RCTs have been done of this kind of wellbeing app. So we were very pleasantly surprised that the application was associated with a significant reduction in GHQ score. So that means improved mental health compared with the control group. So that's the adjusted mean difference there. You can see is minus 1.39. Fairly small effect sizes here. There was also an association between using the app and a reduction in insomnia symptoms. So, as I said, we were pleased that this actually did find a good effect, although they are small effect sizes. We'd suggest that this kind of app would be part of a support offer rather than something that we'd say could help everyone regardless. And there was some varied uptake across different subgroups. That paper is out in BJ Psych now, and there's some further analysis going on at the moment of some of the finer grained details there about the different sort of effectiveness and uptake for different groups. So just to finish, I'm going to just try and summarize all of that, some of which I haven't told you about in detail, so apologies I had to skip over a couple there. But overall, about half of the staff in our group, in our cohort, reporting symptoms, some kinds of symptoms of common mental disorders. But that's not the same as half of staff having a mental health disorder. So our interview studies showed that diagnosable disorders are around 8% for PTSD, 13 to 14% for depression and anxiety. And although that isn't quite as high as the big sort of headline numbers that the media have sort of predicted about this tsunami of mental health problems in the NHS, those numbers are still concerning. 8% of the NHS experiencing PTSD, a diagnosable disorder, is no small thing. And although I had to sort of skip over, there was some concerning numbers about the prevalence and incidence of suicidal and self-harm thoughts and behaviours among our cohort. Overall, in terms of who is most badly affected, typically younger female staff who are most affected, and that's in line with a lot of the other research that we've seen in this area. People who've experienced moral injury as well, in particular, have really been struggling. And I'm sorry I didn't get to talk to you about the moral injury work. Maybe that's for a future session. And male staff being more likely to report alcohol misuse. There were lots of things that people suggested in some other qualitative work that I skipped over there about practical support that would be helpful. So things like free parking, relaxation spaces, breaks, along with the peer support from colleagues and supportive managers. And really key, honest, clear communication from senior managers and government, so that people feel as though they're not being lied to, as though they're not being betrayed, as though they're being actually supported and listened to. And finally, yeah, indications that smartphone wellbeing app was helpful, but there are small effect sizes. And that is onto future work. So as I said at the beginning, we've received some funding to do an analysis of the psychosocial factors contributing to long COVID in our cohort. We've also got funding for this fourth time point data collection, which is going to be going on in a couple of weeks. We're looking at longitudinal trajectory analysis of some of those mental health outcomes over time, so across the 3 time points. And we're also looking at some of the occupational factors associated with intention to leave and sickness absence, which is a really big issue at the moment in the NHS, as I'm sure you are all aware. We've got a mixed methods paper about support services in the works. We've got an ESRC funded PhD student who's starting in October, and she's going to be looking at the data about lower paid healthcare workers. So there's a really interesting piece of work there, I think, about comparative pay and perceptions of pay and mental health outcomes in the NHS. We're also going to be doing a much more in-depth analysis of the post-traumatic growth data. So that's the sense of growth or improvement after traumatic experiences. And we have another PhD student who's going to be using our cohort to try and collect some further data from healthcare workers and their family members about the impact of the pandemic and of healthcare worker mental health on relationships. There's a list of our publications and our funding and acknowledgements, obviously very important. Thank you very much to all our funders and the team. And that's me done.
Well done, Danny. Thank you very much for a really interesting and engaging presentation. It was really lovely to sit here and just listen to some of the key findings from the work that you guys have been involved in. Can we open this up for any questions from the group? I'm just conscious that you have a train to catch. So any questions, comments? Just while people are putting up their hands, I do have a question, and it's something that's always interested me, and it's the issue around post-traumatic growth. And I think it's a really fascinating and interesting area of research. And I'm just wondering whether that area is being given enough attention, particularly during the COVID pandemic, because I think a lot of focus has been on the adverse negative impacts on staff and the wider society. But I do wonder whether we should be exploring in a lot more detail this issue around post-traumatic growth.
Yeah, I agree. I think there's been an awful lot of focus on how terrible everything is and the really negative impacts of the pandemic and of the general context that NHS workers are in at the moment, and not very much focus on that sense that for some people, I know Simon's talked about this in other events, you know, for some people this was an exciting thing that happened and they thrived in that environment of the pressure and this event, this worldwide event that was happening. Equally, yeah, the post-traumatic growth data that we've got, we have not done very much with at all yet, so that's why it's in that future work list. So I think it will be really interesting to look at that, because we and other people haven't really addressed that issue yet because the focus has been so much on the negative. Yeah.
Okay, fab. Jo.
Thanks, Danny. That was really good. And this isn't an area I'm that familiar with, so it was lovely to listen. Just a question and a comment, I guess. The questionnaires where you've identified mental health symptoms, but the lower prevalence of actual diagnosis of disease, Is there any data that suggests that those mental health symptoms are early signs of developing disease, sort of the longitudinal outcomes of people who've answered those questions? Does that tell us anything about people's risk of getting those diseases in the future?
So we don't have that kind of data, unfortunately, in this study. It would have been really good if we had asked for consent from our participants to link to their NHS records, because then we could have done exactly that kind of analysis where we looked at whether answering, say, the GAD about anxiety, whether answering above some cutoff was predictive of developing a diagnosable anxiety disorder that was then treated in the NHS. Without doing the kind of diagnostic interviews that we did in that Lancet Psych study, we just don't know. We can certainly, and this is something we're going to be looking at, we can look at the trajectory of people's answers across the time point, so from baseline to 6 months to 12 months, whether their score is increasing on those measures across that time. That still doesn't necessarily tell us whether they have a diagnosable disorder, but at a point using those screening measures, so there are cutoffs that are used to sort of indicate probable disorder. At a point, you would think that actually the very high scores on those measures do indicate that someone is really, really struggling and probably, on balance of probabilities, does have a diagnosable disorder. So it could be that we could do a bit more work around that, and what kind of score would we use to say, yeah, no, even just using this screening score rather than a diagnostic measure, we can be fairly certain this person is experiencing a diagnosable disorder. Yes, it would be really good if we had done that.
And I think it's really important that you've got that funding for the next phase, because I think in some ways things are worse now than they were during the pandemic, would be my observation. But we'll see. Hopefully
I think
not.
I think that's a common perception, and I think that's why we've steered this next round of data collection away from being about COVID, because it's not really about COVID anymore. It is about the ongoing pressures on the system. Yeah.
Thank you.
Thanks, Joe. Millie, afternoon.
Hello. Sorry, first of all, can I apologise? That was me who was ransacking the meeting. I'm so sorry for that. I was having a complete shocker with my system. So sorry for that. I'm curious. Actually a continuation of what you've just been saying. I was in a lecture on Monday, and they were saying that the suicide the suicide rate of female nurses is something like 2 to 3 times the kind of adjusted general population. They're 2 to 3 more times more likely in the NHS. It was a presentation by Claire Gerarda in Doctors in Distress. And I'm curious what, with COVID, whether it's the same sort of cohorts of people that have shown themselves to be particularly under stress, so the same sorts of characteristics that struggle more generally in the NHS, or whether there are differences, whether that be in role or general or career stage that have come up.
Sorry, I had to skip over the paper about suicide. Sorry, Millie, do you mind muting me? I think it's getting the echo. Sorry. Sorry, I had to skip over that paper. That it is interesting, although interestingly, that there weren't a huge number of covariates that in our analysis that were associated with suicidal ideation or suicidal behaviours. Younger age was to a certain extent, but there's always that issue about younger age being a bit of a confounder, because actually it's the people who are at an older age have lasted if you like, in that system. So there could be an effect there. But yeah, we were a little bit surprised that we didn't find anything sort of more conclusive about that, in a way, that at least in our cohort there weren't strong associations with those outcomes. But you're right, I mean, it is obviously incredibly concerning.
Thank you.
Thanks. Era.
Thanks, Danny. That was a brilliant presentation. Just to pick up a couple of points, because I think we've got some more junior people on the call. So it's to pick up your point that you've just said about suicide, Millie, which is really interesting. Generally, it's unclear. I mean, healthcare work, doctors and nurses, so clinical patient fronting healthcare workers do tend to have slightly higher suicide intention and rates than the general population, but some of that is selection bias. So people who tend to go into healthcare are more empathetic and therefore they're more at risk. And for doctors, certainly there seems to be something about access to so completed suicides. There's something to do with access to the tools to do the job properly. So that's a selection bias. And then Danny also, as Danny alluded to there, there's the survivor bias. So those people who are older have survived in the population, so they are less likely, so the older people are less likely to report suicide intent. And Jo's on the call here, and she'll know the classic teaching in occupational medicine is about people with occupational asthma. If you do a cross-sectional study of people who are in the workplace, you get this survivor bias that people might have report less occupational asthma. And then the other bias, sorry, this is really just to try and help some of those who are more junior, is the framing bias that that we've talked about a lot in the healthcare chat meetings, but you probably don't have time to discuss now, Danny, which is that if you ask occupational groups, if you pose the question about anxiety and depression using GAD-7 and the PHQ, you tend to get higher reported levels of distress and answers in those groups than you would if you didn't select them by occupation. And we don't quite know why that is, but we've talked a bit about that in the group sessions. So thank you. Excellent presentation, Danny.
Thanks. Thanks, everyone. I'm going to have to literally run now. So so sorry for my poor organisation in having to leave early. But thanks very much for the really interesting questions and the opportunity to present.
Thanks, Danny.
Bye.
So if people just wish to stay on for a few more minutes, might be a nice opportunity to update the group on some ongoing pieces of work, and also, I guess, opportunity for people to ask any questions or to chip in any feedback. So in terms of ongoing pieces of work, as you will have all seen, recent email correspondence which has gone out in relation to various NIHR funding calls relating to work and health research. So ERA is exploring different opportunities for respective projects that we will look to write up as funding applications. One of these is looking at, or under the workforce health call, looking at physical and mental health interventions in the workplace. And then there's also the larger work and health development and collaboration call from NIHR as well. And there's a symposium taking place on the 8th of February in London. And I'm not sure how many of you in the group have registered to attend that. But a few of us under the centre are planning to attend that and hope to form some networks with other attendees as well. Our next Lunch and Learn session, Lisa Newington will be presenting a systematic review project that she's looking to start in the coming months. She's just received some funding, and that's looking at work recommendations for people who are accessing physio or hand therapy support in the NHS. So, and the intention for that session will be certainly very interactive. She's very keen to get feedback from centre members. So we would appreciate if you were able to attend that session. Era, I'm going to hand over to you. If there's any final wrap-up comments before we open it up for general comment.
Thank you everyone for arranging. Thank you everyone for attending. I hope you all found it useful, and please spread the word. Thank you very much. And if anybody wants to be involved in any grant applications, just shout.
Thanks, Ira. Any questions or comments from the group? I can't see hands, so you'll have to just chip in.
No one's got their hands up, Vaughan.
Okie doke. All right, everyone. Lovely catching up, and we shall see you in a month's time, if not before.
Thank you. Bye.
Bye.